Morning. Okay, there. My name's Kim Van Herk. I'm a mental health nurse with Inner City Health, and I'd just like to take a moment to welcome everyone. And I'd also just like to say it's really nice to see such a mix of different professionals in the room, because I think when it was Simon's conference, I was like, oh no, it's going to be all psychiatrists. And it's so nice to have a bunch of peers and social workers and nurses and some managers and a whole bunch of different people in the room. So I'm very excited about that. No offense, Simon, but and one of I really appreciate what Eileen, what you said, because one of the reasons I was really excited about this when Simon brought it up was that there's been so many times where I've went to see a counselor about the work I do, and they're like, well, probably the best thing you could do for yourself is to leave the field. And having, fought to try and stay, and seeing colleagues, especially in the last few years, leave. And so I do think, I know for myself, like I'm going to try and really take a moment to embrace who I'm all seeing in this room, because I'm very fortunate to have a really good team I work with that have really helped me be able to keep doing this work. But I think, yeah, the work is lonely. And so that sense of knowing that there's a whole big collective of us doing this, because there's a lot of people I think that still would have liked to have come that weren't able to, is really important. So we're going to start off the day. We're very excited to have some friends from Toronto here to present. So Dr. Michaela Bader and Deborah Pink are with our friends in Inner City Health in Toronto. And so Dr. Michaela Bader is a psychiatrist with Inner City Health Associates and with the ACT team at St. Mike's Hospital in Toronto. Her work is focused on improving the system for and providing care to people who experience severe mental illness, homelessness, substance use, criminalization, and immigration-related difficulties. She is the Director of Mental Health and Substance Use Care for Inner City Health Associates and Assistant Professor at the University of Toronto. She's a Social Justice Postgraduate Education Lead for the Department of Psychiatry. She's also a community organizer working together with allies at Health Providers Against Poverty and the OHIP for All campaign, and on issues of immigration detention. Dr. Deborah Pink is the education lead at Inner City Health Associates. Her clinical practice as a psychiatrist includes the multidisciplinary outreach team, a street homeless outreach team, sistering, and Street Haven Women's Shelter. She is a clinical lecturer in the Division of Adult Psychiatry and Health Systems in the Department of Psychiatry at the University of Toronto. Prior to joining Inner City Health, she completed medical school at Dalhousie, her psychiatry residency at the University of Toronto, and a fellowship in consult liaison psychiatry at Princess Margaret Cancer Center. When she's not working, you'll find her on a bike or on the water. So please welcome.
Yeah, perfect. Okay. We're just figuring out that we actually would like to see our slides and not look back all the time. So excited to be here today. We're going to start by telling you a little bit about how our systems and services are organized in Toronto. And then we'll talk a little bit more generally about some of the work we do with the MDOT team. I'm also a psychiatrist along with Deb on that team. And then we'll talk a bit about homelessness and health. And I mean, I think really want to acknowledge the deep sense of experience that is here in this room. And so I think a lot of the things we are going to be sharing with you today are really to frame the mutual experiences that we have in doing this work. All right, so just to start, these are our disclosures. We have no financial conflicts of interest. We do work with ICHA, Inner City Health Associates in Toronto. I think it's important to acknowledge that the work we do, I've been involved with a variety of different community-based organizations, as was said in the bio, and I don't see myself as being apolitical or unbiased. I think the politics is really central to the work that we're doing with people who are unhoused. We're aware of the privilege we hold as clinicians and particularly as physicians, and we're not here to speak on behalf of people. So this is us. We work on our bikes, but not exclusively. So we do both shelter-based care and outreach. So I work with the MDOT team and with an ACT team. And Deb, do you want to say a little bit more about the work you do?
Sure. Yeah. So I also work on MDOT, which is a street outreach team in Toronto. A couple of days a week, I work at Sistering, which is a health facility for people who are marginalized, as well as Street Haven, a women's shelter in downtown Toronto. And as mentioned, I also am the education lead, so organize all of the trainees who come to work with us as well.
And so just to start with, we'll talk a little bit about Inner City Health Associates. So we provide care. We have over 200 clinicians. I think that number really expanded during the pandemic. We had a lot of shelter hotels that opened up. I don't know if it's the same in all cities. I know a bunch of cities had hotels open up where people who had previously been in shelters were allowed to be in very much more dignified settings, I think, where with your own room, your own bathroom. And during that time, our services expanded a lot. So we have nurses, we have nurse practitioners, we have psychiatrists, and we have family physicians. So you can see here the geographic spread all across the Greater Toronto area, a lot of clusters in the downtown core, but particularly with, I think, gentrification as well as the sort of NIMBYism challenges that we see around shelters opening up. A lot of services are more distributed. And I mean, in a way, it's good. I think that people have choice and that there's other places that people can go. I think the challenge is that there isn't really actual choice because people don't get to choose which neighborhoods they're in. And people are often still faced with a situation of there's not enough shelter beds. So every day people on my team call our central intake line and there's no shelter beds. So we have several different models of care within Inner City Health Associates. We are transitional care models. So the idea is really to provide care to people while they are experiencing homelessness, while they're unhoused, and then to transition them on to sort of more permanent services. But we know that some people receive transitional care for 10 years or longer. We have both shelter-based clinics as well as street outreach. We serve people in a variety of drop-ins, including Sistering, where Deb works. We have a family health team, the Inner City Family Health Team for people who are experiencing homelessness. And then we have a variety of partnership programs, which we'll talk about a little bit more. So the areas of work are primary care, psychiatry. We have a variety of substance use physicians, including from psychiatry, primary care, some people who are merged docs who are doing this work as well. We have a Indigenous health program. We have a regional nursing model, which has 3 nursing teams that serve sort of a geographic area in different parts of the city, which have nurses, nurse practitioners doing both primary care and substance use care. We have Deb doing the education work. We have a population health team that has been doing a lot of things, obviously during the pandemic, but also beyond in terms of sort of more population-based health interventions. And then we have research and QI, quality improvement, also integrated. And then we have a few of these partnership-based teams. We have a PEACH team, which is a palliative team. We have Match, Catch, and MDOT, which provide care partnered with a organization, Loft, that provides case managers. So it's partnered case management and physician and nursing care. We have Scout, which is a team that has been going out into the encampments. I don't know what it's been like here in Ottawa and other places that people have been working, but we've had, because of the lack of shelter beds, the lack of dignity in a lot of the shelter spaces, a lot of people are in encampments, in tents, sort of all across the city, and the Indigenous health programming as well. So just a few quick numbers. We served 7,800 clients, pretty significant increase from the year prior, with over 25,000 encounters, 67 active sites. I think that's probably increased since the slide was made. And you can see that primary care and psychiatry, people usually go an average of 3.5 times. Now there's obviously people who just have one contact and others who have many contacts. So we have one EMR, which is really wonderful. So one electronic medical record across all sites. It's Oscar. And so if somebody is seen in one place and then, at another site in the future, then, there's really good opportunity to have all of the information. Primary care at 59 sites, psychiatry at 44 sites, and co-location at 33 of those. And 76% of clients received care at one site, but there's also some people who sort of move between different sites. And because of the shared EMR, that's really helpful. And over 70 learners a year from a whole variety of different areas, including medical students, residents, and fellows as well.
Okay, so just some details about our team, multidisciplinary outreach team. It's MDOT for short. So we're an interdisciplinary team, and we provide care to people who are living on the streets and or on transit or newly in shelters. So we're made up of case managers, a nurse, and the case managers focus on housing and also all kinds of stabilization, as well as both of us who are part-time psychiatrists. It's a collaborative model, like most ECHA programs, where we are embedded within another agency. And with MDOT, it is Loft. And so, as Michaela mentioned in our introduction, we love to bike around, which is a huge bonus in our work. And sometimes our trainees will come and bike with us, but we also have access to 2 vans because sometimes we're going way out into the sort of the greater Toronto area. And we always see people in a team. So it's very team based. So we're always working with other people. We visit people on the streets, in shelters, in hospitals, in jails, immigration detention. Our team meets without us on Mondays and plans a schedule for the week. And then we sort of hop aboard. Every client on our caseload has a case manager. They have access to the nurse and psychiatry if needed. What goes with this work is intensive collaboration with other providers. So we're constantly working with emergency departments. We're working with inpatient psychiatry units. We're working with social workers. We're really, it's a lot of advocacy and behind the scenes to try to get people the care that they need, either whether it's being admitted to hospital or being discharged to a really supportive place, or holding on until that supportive place is available. So our main tasks, outreach, obviously, we connect with clients to services that they need. So things like, often have people, as you're probably aware, people living rough, don't have access or lose their IDs. So people want to re-get their IDs. We try to get people income supports as needed, access to healthcare, primary healthcare. And when the scout team, the encampment team started, that was a huge bonus for our team, because we have access to essentially a mobile primary care team, 2 nurses and a family physician who are happy to see people anywhere, which has been really helpful. We also try to connect people with immigration legal support and obviously housing. So whether it's shelters, safe bed, transitional, or long-term housing. So we go everywhere in the city. We'll go into ravines, we'll go under bridges, we'll go on the TTC, we'll go into stations, we'll go kind of wherever people are found. This is one of our case managers who used to be on our team, Margot, visiting a fellow who was living outdoors, who eventually we got care and remains housed today, which is wonderful. So we can talk for hours about the details, but we will move on.
So, I mean, we won't go over the definition here. This is from the Canadian Observatory on Homelessness, but I just wanted to acknowledge there's been more and more discussion about using the term houselessness, because a lot of people create home in many different places. And so you may be on the street and still have created a home and a community there, but not have a house. And I don't think we have time to really look in depth at the Indigenous definition of homelessness, but I would really encourage everybody to Google it and to read. It was written by Jesse Thistle with a lot of consultation. and it goes over multiple dimensions, the 12 dimensions of Indigenous homelessness, which is not defined as lacking a structure of habitation, but more fully described and understood through a composite lens of Indigenous worldviews. So I'd really encourage you to spend some time looking at that. I think acknowledging that poverty is a medical problem, it's also a structural problem. It's a problem of our economic system, but for the people we are working with, it is, income is the single most important factor which determines whether somebody's healthy or not. And there's disproportionate impacts in different populations.
So the next couple of slides are graphics that hopefully will encapsulate some of the things that keep us up at night. So this graphic represents what makes Canadians sick, and as you can see, 50% of the reasons is sort of related to your life: income, early childhood development, disability, education, social exclusion, and then healthcare is 25%, biology 15%, environment 10%. The next couple, we've been wanting to update these slides in presentations we've given, but they're almost 10 years old, and so I am assuming the numbers have gone up, especially during the pandemic. But as of 2014, 35,000 Canadians are homeless on a given night, and over 200,000 experience homelessness in a year. And you can see a lot of people are unsheltered, living rough on the streets. More people are staying in shelters, and there is a significant number who are provisionally accommodated. So 27% of people who are homeless are women. Nearly 19% are youth, and families stay in shelters twice as long as individuals. I think it's also important to highlight that around 30% of the shelter population is Indigenous as well, whereas 4% of Canadians, so drastically overrepresented. This is another older slide, but I think really paints a picture, and I think we're maybe a bit preaching to the choir through this audience, but just to see the cost of sheltering people in emergency settings. So around $2,000 a night for a shelter bed, $4,000 a night to stay in provincial jail. Monthly cost. $2,000 for a shelter bed for a month, $4,000 in jail, about $11,000 for a hospital bed. And again, this slide is from 2012, so probably aged. Whereas $700 for a rental supplement and just $200 for social housing. So really, like, the economics are there, and I think it speaks to the importance of the bigger pictures, sort of the policy and the structural issues. One of the things that we talk a lot about is income supports, and ODSP rates have barely increased in many years. And in Toronto, trying to live on $400 for rent is impossible. So as you can imagine, homelessness cuts life short. You want to do this?
Yeah, I think we can maybe even skip this slide. I think these are all pieces that we know and are well aware of. But wanted to just acknowledge that there are really difficult ethical questions that come up. Are we providing coercive treatment or person-centered care? I think the coercion level, particularly with community treatment orders, is really complex. Lots of questions about sort of, how do we really engage with people longer rather than just sort of brief encounters. I think hospitalization can play a very important role in stabilizing somebody, but then how do we remain engaged after that? Resource allocation, I mean, a lot of the work happens with case managers, with nurses. Physicians are, I think, one very small piece of that. And I think as physicians, that's something important to consider. I think, again, what role does primary care play versus psychiatry? And I think, there are many more, and hopefully throughout the conference, we can delve into some of these. So do you want me to keep going, or? Okay. So I think, again, we can maybe sort of skip over some of this, but just to say that there are lots of skills and clinical pearls that we'd be happy to share and discuss over this conference. I think a huge part of it is connecting with people's resources and supports, and realizing that people have community on the street, in shelters, And we're often intersecting with people's lives just in very brief ways. And if we can support people in their communities, that is so, so, so important. And then just really the last couple of slides to acknowledge that really this is about wealth inequality. This is about poverty that is manufactured. It's about our system of capitalism, the way our economic system is structured. This is about colonialism. I think that it's about racism. Poverty doesn't exist because people are poor. Poverty exists because a system has been created and is upheld that continues and perpetuates people living in poverty. There's a lack of housing, like there are no shelter beds, there is no housing. These are things that could be created, that are being created, but not sufficiently. And in addition, I think the social and political exclusion. And so just, the solutions have to occur on multiple levels. They have to occur on the individual clinical level, on the programs we designed in communities, but then also on the systemic level. And just to end on this slide, that a lot of the way that I remain engaged in this work is by doing the systemic advocacy, along with Maggie, who's here as well, and another resident from Toronto who will be presenting later this afternoon. And I think that, again, just very personally, is how I maintain hope in doing this work, is by working both on the individual and the systemic level.
Thank you all for our whirlwind tour participating.
Thank you.
I loved it because your clinical pearls were exactly like all the same as what we teach our nurses too. I was like, oh my gosh, that's such a thing of beauty. So thank you for that. We're gonna ask Deji, can you come on up here? So Deji is gonna present next. He's an associate professor with the Department of Psychiatry and Psychology at Queen's University, Kingston, where he is also the clinical director for community psychiatry at Providence Care. He's also specialized in addictions. He is actively committed to supporting equitable care for individuals with severe mental illness and concurrent disorders in the community. With an executive MBA, Deji is on the advisory of a number of national and international mental health policy, and advocacy organizations. So please welcome.
Thank you. Good morning, and thank you for the opportunity to speak today. I certainly thank my sisters and family on the streets. And what I'm going to do is present from a smaller city, Kingston, #YGK, and some of the differences. I mean, for instance, we don't have metro in Kingston, but we sure have streets. We've got woods, we've got rocks, we've got junctions, and my experience is probably tailoring in, doing street psychiatry also as a Black man, which is probably a completely different gig in a fairly different demographic community as Kingston. In speaking today, I thank my professors, who are people with extreme knowledge and experience of living on the streets. And I thank them for all they've taught me and continue to teach me. And the numerous times all my medical education has been exposed as being inadequate. And also continue to train me in the basics of humanity, which somehow we sometimes begin to lose those skills as we acquire alphabets behind our names. So I thank all people with lived experience, the peers who continue to train me and mentor me. So what is street psychiatry? We've got a rough idea what a street is. I mean, you would have known that since you were a kid. But what does it mean to actually practice on the streets? And what skill sets, what do we take into those spaces to be functional, and whatever we do no harm? So just quick show of hands, how many of you here, learned people, had formal training on what to do and how to practice on the streets? 1, 2, 4, 5 maybe. And look at the number of people here. So most of us have had to sort of learn, continue to learn, and we're all at different stages of learning. I consider myself still in kindergarten. There's just no way I can even fake being streets as a Black man with what may sound like a hybrid British accent. There's no way I can go undercover. And so for each of us, we bring unique experiences into this. Now, a lot of psychiatry, the way it's formally recognized, is carried out within walls. But within walls, there are also power structures. You arrive at the hospital, there are probably security there. You go in and some people can just walk in, tap, tap, and they walk through. Other people need to sit somewhere in a reception waiting area. They're waiting to be called in. And then they can only turn up at the time they were given a scheduled appointment. And then the person with power invites you into the room, offers you a seat, you have your chat, and when they're done with you, they ask you to leave. But sorry, I've got another appointment coming up, and we'll continue the conversation next time. And it's a completely different power milieu because the structures there, right down to the appointment and how you're processed and so on, really is a territory that's structured. Working on the streets doesn't have those walls. You're meeting people where they're at. And that's a completely different power structure and skill as well. Because how good are we at meeting people where they're at? And that really means recognize that the power we have as a psychiatrist, a social worker, a nurse, or whatever role we play, doesn't apply by the same rules. The last few months have been also very humbling for me in my own education as a health professional, because I'm currently living with long COVID. And if I stand for too long, hence, thank you, whoever provided this tall chair, I'm going to start feeling a bit dizzy. And now I know what it's like to have palpitations that feel like a railway junction. Or, having experiences in your chest that are like being on a roller coaster. The things patients have probably described to me or people I've served for many years, and I thought I understood till I didn't. Now I know what it's like to be struggling to breathe. I thought I understood that. Now I know oxygen sats are they're not just numbers, but behind oxygen sats and those numbers is a human being contemplating their next breath. I'm a lot more literate about how the body is designed to have the heart and the lungs on mute. And when they come off mute, whether through a panic attack or breathing difficulties or struggling with an overdose, when your heart comes off mute and your lungs come off mute, it's a completely different headspace. And this is just a bit of early learning I've acquired since February and I continue to develop. So the bulk of psychiatry and mental health service provision is actually in the community. And I challenge many of my colleagues, hospitals are based in the community. Just like police stations, just like fire stations, just like the shopping mall, they're in the community. And the bulk of work being done is in the community. The bulk of mental disorders are in the community. Yet, how many people are actually skilled to do that? So unhoused individuals with mental health needs face multiple challenges: stigma, labeling, difficulties with access to follow-up. We've heard from our colleagues so eloquently the challenges. And stigma is pretty nasty. And it's not all about race and so on, but sometimes as health professionals, we can label people and give them the most awkward experience. I'll use a biographical example. I'd registered with a dental practice in #YGK. I was in the chair, and whoever's had the vulnerable experience of being a dentist chair, you're there and you do as you're told as the devices are whirring and purring away. And I saw the dental assistant looking really anxious. And she stepped out of the room and I thought, hold on, what's going on here? And I could see her whispering to the dentist. I thought, what's going on here? And then the dentist came in with all authority. We need more information from you. we need the details of your psychiatric medication. I thought, goodness, this is a wicked dentist with such a sense of humor. But, but he was really serious. He said, we need the full details of your medication. We can't go through the procedure without the details of your antipsychotic medication for your schizophrenia. I thought, where did that come from? So, oh, because your records say, as part of your work experience, whoever was getting some of the initial details, that early psychosis and community and streets. I said, no, I'm the medical director of that program. I'm not. And it came to pass, the dentist thought I might bite his hand off. I mean, he was really anxious that if I had a mental illness and they were doing that, what if I went and just, got a juicy hand? And these are the experiences that many of the people we work with, that we serve, don't have the privilege of a podium like here to talk about and have those sort of voices. So streets, the work we do also involves being actively engaged with often marginalized people. We talk of equity seeking, but I'll add a few more equities to it. Some people are equity seeking, some people are equity deserving, so they don't even know to seek the equity. And some are equity demanding. And a lot of people we serve are equity deserving. They're not equity seeking. Many don't know their rights. They don't have access to human rights lawyers or the advocacy and so on. And it's incumbent on us to make sure people receive equity, that even if they're not demanding equity or seeking equity, that they're deserving. So I'll sort of invite us with our vocabulary today to stop using the term equity seeking for everyone, because even seeking involves a degree of privilege. Not everyone knows their rights to seek, but they still deserve. The work we do on the streets requires mental health professionals to learn and continue to learn and grow in a less familiar ecosystem. These are the corridors of hospitals where you're very comfortable, you've got your fancy lanyard and so on. But an ecosystem, as we saw from our colleagues in Toronto, under a bridge, footprints in the snow, by a rock, a junction, and so on. And it's a completely different ecosystem. And in doing that sort of work, what sort of kits do we use? Now, intuitively, we know how to do these things, because if you're going for a hike, you're probably not going to dress in a suit with your Louboutin heels or fancy wear. Somehow we do all have a capacity to adjust based on climatic conditions. For instance, I would certainly not wear a t-shirt in -10, not to talk of -20, 30, 40. But do we make similar adjustments respecting the work we do on the streets as well? Now, in Kingston, we have a group that comes together as a homelessness initiative, and I think it's an incredible group, and each city or population would have their own partners. We heard those in Toronto earlier. So for instance, in our homelessness initiative, we've got membership from mental health and addiction services, health providers, including street health providers, ACT teams, assertive community treatment, primary care, police, including the chief of police for Kingston, people from corrections, the City of Kingston, United Way, the library, youth resources and workers, shelter providers, people supporting food security, peers and experts based on that experience, and vocational services. And this has been, personally for me, attending the meetings, very rich learning. Learning from corrections. What happens? Kingston as a city has 4 main pillars: Royal Military College, the universities and colleges, corrections, and then the health services. And what happens when people leave corrections? Black bag in hand, perhaps no ID, nowhere proving they're who they say they are, to no address. Life goes on. And I've heard people say, actually, The first thing I thought of doing was getting back because I knew I'll have food security and all the rest. So I thought I'll just carry out just a small enough offense to get back in for a few weeks while I was trying to figure out my life. Or people are leaving corrections without medication. So talk to your GP. Alas, there's no GP. Follow up. What address? Tent 17 by the birch tree down the 6th lane near a dog walk path and so on. And these are our brothers, sisters, and members of our communities. So for instance, when we think of our kit for street mental health and street work, what do we wear? What symbols of power do we bring into these spaces or not? What do we do to authenticate our identities? I've been challenged several times or working with someone on the streets and someone asked the other person, are you okay? And I'm wondering, I didn't just mug this person. I'm trying to provide care. Advocacy, which is an incumbent skill with the work we do. The interagency working with partners, and really quickly giving some examples. Christmas and Thanksgiving every year, I volunteer with our homeless shelter, not as a doctor. And I'll give away my street name, it's Snoopy. And I've learned more from volunteering than being a doctor. So when Snoopy's on toilet shift, you put on the timer for 5 minutes and knock, knock. If no one's responding, you check in, and it might be someone needing a resus. Meals. And a quick example, someone I tried to work with clinically as a psychiatrist for 2 years in my power structures, and the person just had nothing to tell me. As a volunteer, 2 a.m., one fall, doing the security shift with a flashlight, this person got chatting with me, not as a doctor, and just shared their experience of having been an artist in Toronto, losing everything in life, including the gallery, loss of eyesight. And the person was sharing with me how the next few days may be difficult because they're thinking of the anniversary of their mother's death. 2 a.m. fall, a chilly evening, I realized this person I was serving and I shared the same anniversary for our mother's deaths. That was an experience in humanity that grounded me. So wrapping up, the sort of work we do on the streets is based on a pillar of humanity, recognizing that these are our fellow people. Any day, if I've got to take people to a desert island with me for survival, I'm going with people from the streets. I don't want some fancy-dancy professor with alphabet behind their names. I want someone who knows how to survive. And I think an ethic of working on the streets without walls is never giving up on anyone, ever. Thank you.
A little bit of time for questions if from the audience, if anybody has one. I'm going to start then. I was wondering, in both Kingston and in Toronto, are you guys seeing a lot more people, refugees coming that are crossing the border from the United States that are ending up homeless?
So I mean, I don't know what the exact numbers are, so I can't give sort of a precise answer. I don't think clinically that I've seen a lot more people. I mean, I think we always see people who are struggling with a whole host of different immigration related issues. I think we've seen a very cruel policy change happening recently with the closing of Roxham Road, which I think will lead to people taking many more risks in order to come to safety. And so I definitely think that, I mean, there's really big things, bad things happening within Canadian immigration policy that impact our clients. I know in Toronto, there's been a lot of discussion that's very xenophobic, that's very racist about the impact of migrants coming, and that sort of saying that this is part of the reason why there isn't space in the shelter system. And so I think it's really important to counter that right from the start and say, you know, the reason we don't have shelter beds is because of structural issues. Like there are not enough shelter beds. People don't have enough ODSP. There's not sufficient ways that people are cared for in our society. And it's not about people who are migrating. So I think that's, so while I don't have a precise answer, I mean, those are sort of the discussions that I'm seeing play out and that impact the, you know, just the way that we think about the spaces that we have available.
Well, Kingston's probably not as characterized by that. So it's not a natural border crossing city to end up in. So whilst we have migrant populations, they're not fewer people crossing the border. There are people seeking asylum and refugee families, individuals who come into hard times with employment. Affordable housing has become a critically challenging situation. And there are people who, if I can use the term very loosely, hoard property, including students. So we have some students from very wealthy backgrounds that are landlords to their professors, just because they have that sort of purchasing power. So it's a slightly different, each city and ecosystem is unique in its own way.
It's okay if I add one more thing. So this is a little bit unrelated specifically to homelessness, but in the end of March, the beginning of April, the provincial government cut access to healthcare for people who are uninsured. So I've been really active in that, sort of not related to my sort of work, but from an advocacy perspective. And I have definitely seen this impact people who I'm working with who are experiencing houselessness and also don't have insurance coverage. And so we have seen and will continue to see, I think, worse access to healthcare for people who don't have immigration status and who are now not able to access care. Sort of, it's taken us back to pre-pandemic times, which is very concerning. So just wanted to add that, yeah.
This is for Dr. Bader and Dr. Pink. One of the things I saw on your slides is the large number of trainees you've been able to get through your program. What strategies are you using to recruit medical students and residents? Like in Ottawa, we've got a sort of model-sized program. I'm one of about 3 residents in the past 10 or 12 years that have done outreach as a core severe and persistent mental illness rotation in residency training. So I'm just curious as to how you engage people to go there.
So I think I can answer this question on a couple of different levels. I think it takes people like Michaela, Dr. Bader here, who advocates to the university, because I think there's a lot of pre-planning for residency curriculum. And so I think advocating for specific blocks in residency to be dedicated. I think there's one in PGY1 for psychiatry, which is an underserved. And so people can choose between a bunch of different sites. Outreach Psychiatry, our program is one of many sites. That's sort of thing. It takes the advocacy to make the rotations available within either medical school or residency. I think that's the first step, and then having programs that appeal to residents as well. So I think for us, there's been like we've been any month that we offer MDOT is very quickly filled. I think and I think it's mostly word of mouth. I truly do. I think residents really enjoy getting out of the hospitals and being with the team, like collaborating and learning learning like while doing. It's like very much sort of like unlearning psychiatry. I feel like when people are with us, we kind of have to rethink the way we practice. We're not going to see someone on the streets and finding chairs and sitting for 45 minutes and doing a full psychiatric assessment. Whereas like, would you like a coffee? Like what is it that we can help you with? It's really, really quite literally and figuratively meeting them where they're at. And so I think it's quite refreshing for learners, for trainees to come and see that in action. And I think also really the collaboration of working with our case managers who are so passionate and so dedicated to the work. I think they find that very rewarding. So a lot of PGY1s, like as at the beginning of their training, will join us, and some will come back in PGY3 and PGY5 for further stints with us. But I think people do speak highly, and that sort of leads to more people wanting to come.
So is your underserved rotation specifically outreach? Because here at Ottawa, trainees will consider anything that is not working in the Ottawa hospital as underserved. So I'm wondering, is that something that you have actually mandated in the curriculum at U of T?
So the underserved and marginalized populations selective that I've been running for the, past 6 or 7 years in Toronto, we've had a lot of discussions about what underserved is. I think that people are like, everything in psychiatry is underserved. Can I do a perinatal mental health selective in a wealthy part of the city? And it's like, no, you cannot. And so I think that that's a really, we've worked really hard to try to create options. So it's 1 month in PGY1, and then it's going to be 2 months in fourth year medical training to really select opportunities where people will think about socioeconomic marginalization. And I can say, like, in my role as the director of mental health and substance use care, this is all very self-motivated. Like, I need to have psychiatrists to hire. So if anybody wants to come to Toronto, we're always, we have many spaces, and we're opening up more shelter clinics like continuously. And so I think without gaining the skills in residency, people will not be that drawn to this type of work. So, not to put you on the spot, but Maggie's right here, who spent some time with us as a resident on MDOT. I don't know if there's anything you'd want to add to that. Sort of what draws residents to this type of work.
Yeah, I was very lucky to work with Michaela and Deb multiple times in residency. I'm going into my R4 year. I think like having it built into the program made it really helpful, because then like for people who like have no idea of what's available, like it's presented to you. And then I think because of the hard work you've done over the years, like our program is getting a bit of a reputation for having these resources available. And so people who are more interested are more drawn to it. So I think there's really kind of like an exponential sort of growth in that. I would say most people in my cohort are interested in this kind of work in some capacity, which is really great. I think there's also like, not to brag because I'm part of this group as well, but like there's a small group of people who are more interested in more of the like political organizing. And so then it kind of passes, like, it seems like it's a big issue in Toronto because there's so many different clinicians and physicians and like healthcare workers advocating in different spaces. So I think it feels like a closer community. So it feels easier to get into, is my perspective. Yeah.
So from small city, but university as well, Queen. So I would say also wherever possible, we can have these programs very early. Programs that have people beginning to be learners become aware in their fourth year. It's getting pretty late. And the earlier in career, PGY1, postgraduate year 1, bringing in people we're developing a program, getting emergency docs, early career, family doctors, early career, people in psychiatry and addictions in the earlier years. So while people are still impressionable and begin to see things, over and over again, I see people in their fourth year realizing, oh, I never knew I was discharging people to the streets. And I've been doing that for 4 years. Oh, I thought the hub was like a bed and breakfast and people get in and so on. So whilst people can still engage early and then build on it over the next few years, the better, rather than late career. And it's inviting all of us to advocate and lobby for these experiences, whether it's nursing, social work, or occupational therapy, addictions, and the range of areas we work in, to be quite early, let people feel it early.
Just add on a little bit to what you're saying. In addition, I think when we have our first year residents coming with us, we end up seeing them in their PGY2, PGY3, not on MDOT, but in hospitals, in emergency departments, on the inpatient units. And it selfishly is so helpful for them to have the experience so that they know that this person, is not just, they know what it looks like for someone to be living on the streets. They know what it's like to work with our team. And they also, I think, know that when we're advocating for someone to stay in hospital, we really need it for them. And so I think it's so helpful for the functioning of our team to be able to have trainees who come with us and then spread out all over the city. And then we end up seeing them and they're able to sort of assist in helping for with our patient population. Yeah.
Great. Okay. One of my questions was around, like, if you could speak on the role of coercion, because I think something I struggle with in being interested in this work is it feels like an extra level of like going out to find somebody to put them on a form and bring them into the hospital, when that can be really traumatizing. And that's something I'm constantly grappling with, of this, people deserve access to psychiatric care and also have had so many experiences of institutionalization. Like, what is your role as a healthcare provider? And are there times where it's actually better that psychiatry is not involved, given that we do have this like obligation to be putting people in the hospital against their will and acting on their behalf? So I'm just curious about your thoughts on that in this work.
I'll try and give a shorter answer, and then hospital is just a fraction of a person's life. And I think if we do have to make the very difficult decision, and I totally agree, when we want to support people to go into hospital for care that they can't receive in the community, it's because we really, really feel it's important. And a good chunk of the battles and the work done is actually against colleagues. Also stigma, or the person has a personality disorder, it's just addictions, it's crystal meth, what can we do? They won't get better and so on, and they're out again. So it's quite important, apart from the process to get them in, which also is advocacy when the first responders arrive with the police, getting some information across the emerge in advance. So they're expecting the person. This person may not be able to sit in the emergency department for 4 hours and maybe quite agitated and so on. But also, as the person going through their recovery journey, where possible, in reach the hospital, helping those who are providing care in that setting better understand the person and so on, and then supporting the transition back out. So it's like a street to hospital back to street cycle of support. And hospital's so artificial. It takes a few days of a wash and a shave to make anyone look spick and span. And they could look quite well because they're probably not accessing substances or other things, but that's not the end of the recovery journey, and it could be cyclical. So our job is also cyclical. In reach is part of it.
Thanks for that question, Maggie. I think it's a huge challenge that I think I personally grapple with on a regular basis. And oftentimes, Michaela and I work on different days, but oftentimes I'll call Michaela, be like, I don't know what to do. And I think it's a huge challenge. I think ideally it'd be great if police were not involved with the forming, with the certification process. I think that would make things tremendously less traumatic. I think, I know we've talked about this a lot in your elective with us, or selective, but ultimately I think it's a matter of safety, and ultimately I'm worried about the health and the survival of someone when I do certify them. I think, I just recently read a book by Paul Farmer, about Jim O'Connell, Tracy Kidder. It's about the Boston Homeless Project. And there's an anecdote in there where this family physician who's working on the streets in Boston for many, many, many years. He was working with a woman who just refused to engage. She would just swear at him and quite mentally ill, and wasn't able to get anywhere with her. And then several years later, he goes to a board meeting, and it turns out she's a board member on a social service agency. And he's like, "Wow, you look great. Like, this is incredible." And she's like, "No thanks to you. You left me out there suffering." And it was so moving to me just to realize that, people sometimes aren't able to ask for help, but in retrospect, they do want the help. And I don't think it's, necessarily across the board that way. And I think the certification issue is certainly a case by case basis, but I think structurally, I think we can make some changes in making it more humane. And I think I agree that hospitalization is just one piece of the puzzle, and it's not forever, but I think it's sort of a really good jumpstart to stabilization. And yeah.
I've worked in several different settings, currently Toronto, now here in Ottawa, and I'm sort of almost having to relearn everything that not everything that I know, but certainly a lot of what I know based on, and so having developed programs in your relative cities, just curious if there's some advice or challenges or experiences that you guys have had to sort of reduce that, I don't know if it's called reduce or ease the learning curve a little bit. That's it's so implicit in the space of the community work, how to smooth that transition a little bit, or things that you've learned through developing a program, on staff, developing, if that makes any sense, and how to provide clarity.
Happy to start. I mean, I think that a lot of it is sort of one of the things we had on our slides, like relationship, and finding that community, meeting people who you can call. None of this work is able to happen in isolation, I think. And so the setting up networks of mutual support so that people can have a connection. So I don't know all the resources. I will never know all the resources in Toronto, but I know who to ask. And if that's not the right person, then they'll pass me on to somebody else. And so I feel like that's a big part of the success. I mean, when we hire a new psychiatrist, for example, I mean, we do an onboarding for people. There's been sort of various versions, and Deb can speak to this more, of groups meeting after hours to provide sort of support to each other. Sometimes people come, sometimes they don't. I think a lot of the times it's really who you feel connected to and who you feel you can reach out to. And I think that the benefit of the inner city health associates model, which is not without some challenges, but is that we're embedded in organizations. And so, the psychiatrist might change or the family doctor might change, but the organization has been running for many, many years, and they're embedded in the community and they know their resources. Now, I think we've seen a lot of challenges, sort of quote unquote post-pandemic, but end stage of the last the last year of the pandemic. I think a lot of people are burnt out and are leaving, frontline shelter workers with deep experience. And I think part of that is because huge demands were put on people. I think part of that is because people are underpaid for the work that they're doing. And so at some point, that just doesn't weigh out, right? And I think we need to be paying people better who are working front lines. And I don't mean physicians here. Anyway, I don't know if that answers your question, but just some thoughts.
The other bit also is each ecosystem is just so unique. And we must be open to learning and unlearning, unlearning. Nothing in all my British experience prepared me for Canadian winter. I could have read that for a million years. You've got to be there. And I'll say, to work in this sort of space, I'm going to draw from a term that's sometimes used with the special forces as well, which is VUCA, V-U-C-A. And are we able to work with volatile situations? So V for volatility. Are we able to work with U, uncertainty? Are we able to work with C, complexity, and A, ambiguity? You know, if you're very obsessional about nano detail and expect everything to work precisely the way you want it to work, you'll struggle working this space. There'll always be a curveball, and can you adapt to it? And it's not going to be a space for everyone, because volatile situations that are uncertain, they're complex, they're ambiguous. People are asking you for very precise answers. So how do you think, or how long do you think it'll take? You don't have answers. Yet, in not having answers, having the confidence, building confidence and relationships and trust that allows you have a way of containing that in yourself as well and with others, and dealing with the trauma, loss, difficulties that come in this space. So it's never going to be for everyone. It does require VUCA in each of us work in the space and the ability to learn and unlearn. If you hold on to your Flintstonian knowledge, you'll fail in this space. And it's adapting to new street drugs, new vocabulary, and etc.
Two questions, one of which I think is going to be a very short answer. We've heard from two cities. I just wondered, is there anyone in the room who has expertise in rural homelessness? Because it's one of those, yeah, okay, yeah. Because it's one of those things where nobody talks about. You know, all the homeless services are based in cities, but there's people sleeping in fields and barns, and there's issues with transport. It's a very. I think maybe we can hear from you later. I think it's very different with the city stuff. So I maybe I had a blind spot for that. Maybe we should put something like that on the agenda. We'll do that next time. But something around rural homelessness. And the second thing is the whole coercion thing. I mean, there is a power differential, and I think it's dishonest to pretend that there isn't one. I wondered if people had got experience of using advanced directives for this. So when people are well, you know, you can have a conversation with them and put in writing about if such and such happens, I need to go on a form, or how the form should happen. And of course, so that's part of it. But the other thing about coercion is it doesn't finish when it finishes. There's always the feedback afterwards. And do you think it was right for us to do that? I mean, I know there's been some research done on that in non-homeless populations, but I just wondered if, and it sounds like it's a topic we should investigate, but you know, do you think it's actually the right thing to do to make you go in hospital, and how could we do it better? So I think we can tease it out a bit and maybe do it better around having our advanced directives and doing and completing the feedback loop. I don't do it very well, but I think we should be thinking about maybe doing that.
I don't do, or I haven't done advanced directives with anyone yet. I've not achieved that. Some of the rural experience, certainly seeing people in fields and locations where the next community is about 3, 4, 5 kilometers off, living in a field, or someone living in a swamp. I've done a few of those in Southeast Ontario. With regards to the coercion bit, what I aspire to do, not always successfully, is after someone's gone into hospital, to in-reach them and continue that journey of debriefing as they recover. And I found that really helpful in then receiving the person back in the community, because if their last experience was police cars and going into a van and shouting in a moment of very paranoid distress, for instance, if that's the last contact, and the advantage of in-reach also can be that you're seen as facilitating leaving hospital as well, and as an advocate, and that can actually further strengthen the therapeutic relationship.
So I did a grand rounds presentation in my residency on advanced directives, and then have never done an official advanced directive. So I think that's a really, really good thing to think about. I have done sort of versions of that, you know, sort of talking to somebody, what are the early warning signs when you're becoming unwell? What would you like us to do? What medications do you like? Sort of advanced direction-ish. I have to say, like, that it's always felt really helpful in the moment of having the discussion, but in the moment of crisis, it's, I don't know, I found it not clear if I'm using it in the right way or sort of, but then I will say that I'm always surprised by how forgiving, how open people are to coming back to care, even if the experience of a form has been difficult. Not always, but oftentimes. And I think the lesson that I've sort of taken from that is it's so individual, and I just have to trust that, you know, it's different for that person. And I always ask, how was the experience with police? How were you treated in hospital? I haven't asked the question you're suggesting before about, you know, sort of, do you think I made the right decision or what? So I think that's really, really helpful to think about. I mean, I will say that the work, particularly as a psychiatrist, has so many connections with the policing system. And we're very lucky in Toronto that after a lot of community-based advocacy, we now have we have 4 non-police-based crisis response teams, which is really, really good. So that there are teams that can go out when somebody's in crisis and not involve police. I find it difficult though, because I'm part of a group called Doctors for Defunding Police. I think we need to look at taking budgets from the police, taking money from the police budget and reallocating it to social services, to housing, to lots of supports. And at the same time, while I'm involved in that advocacy, I'm also still calling the police and doing forms and doing, you know, community treatment orders and all of those aspects. And the way that I sort of cope with that, back to Maggie's question, is ensuring to have those discussions, to acknowledge with my team that calling police has risks, can be lethal, particularly for Indigenous people, particularly for Black people. Like, we know that the experiences that populations and individuals have that are deeply embedded within structural racism. And so having that discussion with our team really openly, so that we're thinking, like, is there anything else we could be doing? Is there another way that we can engage somebody? And if at the end of that discussion is like, well, actually, we're really concerned about this person's safety, then, you know, we proceed that way.
Hi. I just have some comments, really, and I'm going to read from my notes because I'm very uncomfortable with talking in public. So I don't have any university background, but I do have 38 years in working either in frontline or in management in social service agencies. And I'm very impressed with this multidisciplinary group, MDOT, that you're both a part of. And I definitely see that that's something that we could benefit from here in Ottawa. So learning how we could go about doing that. The idea of including that as part of residency for the psychiatry program is a great idea. And early on, as you said, I can empathize with the heart palpitations, by the way, not for different reasons, more anxiety right now. So one of the things that I wanted to comment about was the power differential that we spoke about earlier. It does not just exist between professionals and clients. It also exists between professionals and folks working in frontline. And basically, especially in the last few years, working in some of the centers that we represent, it's like triaging in an ER. And we're trying to protect community members from neighbors and neighbors from community members. And it sort of all falls on us. And it's really difficult because often we're seeing people, some that I've seen over the 38 years that I've been doing this work, that are still chronically unhoused, struggling with their mental health, and to see them decompensate and not being able to actually get them the help that they need. We have partnerships with mental health professionals, but the way the services are structured, they're unrealistic. It's Monday to Friday between 9 and 5, and you're supposed to be well after that. Same with addiction consumption sites, Monday to Friday, ending at 5, and your addiction is okay until the next morning. sorry, I guess that's pretty much it that I wanted to say. It's the sense of powerlessness because we have the relational piece down pat. We're every day in the trenches, as it were. But there's that lack of that differential in power to do anything with that and to support people with that.
I would like to say, Liz and I met last night and we were really happy because we both remembered each other's names today. But I think what you're talking about is a really powerful thing. And sometimes as a mental health nurse, you know, partner agencies will come to me with that helplessness of, Kim, like we've got to do something. And that hard thing of having worked with people where, you know, we talk about this a bit later in our presentation because our clients do become a second family for us. And so that hard thing of carrying their wellness on our hearts. And yeah, often getting treated really horribly. I think as professionals in this work, peers, nurses, social workers, case managers, psychiatrists, we all have stigma that we also encounter as people doing this work. And so that hard thing of, yeah, when our communities are saying, you know, we don't want your people here, you know, we don't want your family here. Well, you know, it hurts. And to keep fighting for them. And while we're seeing people die and people get sick, it's a hard thing. So I'm with you, because I mean, I think I see it in I see it as a nurse and knowing that I have a little bit more power to do something. I see it in our psychiatrists having that power and also struggling with what to do with that power. And so I think we all feel it here. And I think that's part of the importance of coming together because it's a hard thing and it's part of the loneliness of the work. Yeah, and thank you for doing like this 38 years. It's a hard thing to do. So yeah.
Thank you. Just add to that, and thank you so much, Liz. You're right, and I think you flagged something else we should take away from today, which is respect for all our partners and those who work in different agencies. A person may not have the medical or clinical vocabulary to say things like hypnagogic hallucinations and so on, but it doesn't mean as experts in the field they've not made valid observations. Now, the way they may frame the language may be different, but that's a lot of experience. And probably just to honor your experience, Liz, as a show of hands, how many people put up their hands to say they've been working in their area of expertise for over 30 years in the room? Not very many. So in a way, you're pretty much like a professor emeritus in that space. And we can't ignore that sort of knowledge and so on. So thank you. I think it's just so important that we do respect. And you're right, sometimes with that power imbalance, you know, someone walks in and then all of a sudden takes control of that situation as if it's theirs to take control of. And the worker who's made the most observations, who made the call, is just ignored and silenced. So thank you, Liz. You're our professor emeritus of the day.
So do we have time for one more question, Nicole? And then a quick one. Okay. Yeah.
I mean, I was just going to say, yes, that happens. I've seen that happen. I mean, I think so many ways, especially the more institutional you get in medicine, the more rigid it can be, and people are sort of on their own track. And I think there's a lot of work that has to happen, advocacy, both on the individual level, but also the more systemic level. And I think part of this is medical education as well, to actually know what to do when somebody comes in with advanced directives in whatever shape or form. I mean, people do RAP groups. We have those as part of my ACT team now. Like there's different ways to capture the things that are important and to note those down. And I think there's huge gaps in how institutional spaces respond and integrate that.
Okay, so we're going to take a 15-minute break now.